Imagine, just for a second, that you're sitting at your kitchen table.
Right, just a normal day.
Yeah, exactly. You're just reaching for a simple cup of water. It's this movement you've done, literally millions of times. You don't even think about the mechanics of it.
You just do it.
Right. But this time, as you extend your arm forward, something is just horribly wrong. Suddenly, your shoulder feels incredibly loose.
Oh, man.
It feels impossibly heavy, completely unsupported, like it's just hanging there, disconnected from the rest of your body, as if gravity just suddenly singled out your arm and is trying to pull it straight down to the floor.
And for countless stroke survivors, that terrifying sensation, I mean, it isn't just a thought experiment. It's breakfast. It's getting out of bed.
Right.
It's this very visceral, everyday reality of trying to navigate life when the brain essentially loses its connection to the arm.
And when that connection breaks, gravity usually wins.
Yeah, it really does.
But right now, the medical community is trying to bypass the damaged brain entirely, right? Like hot wiring the shoulder muscles using something called functional electrical stimulation, or FES.
Exactly. FES.
So today on this deep dive, our mission is to really figure out if zapping these paralyzed muscles actually works, or, if it's just another piece of flashy medical hype.
Which there is a lot of.
There is. So we've got a fantastic stack of sources to guide us today. Specifically, a major 2015 systematic review and meta-analysis from McGill University, along with some really illuminating clinical perspectives that break down what this actually looks like in a physical therapy room.
The real-world application of it.
Exactly. Okay, let's unpack this. We are going to dig into the exact biomechanics of drop shoulder, why a seemingly microscopic shift in bone position matters so much, and the hard truth about whether this electricity can actually, cure pain and restore your ability to move.
Yeah, and to understand why a therapy like FES even exists in the first place, we really have to look at the staggering scale of the problem it's trying to solve.
Right, lay out the landscape for us.
Well, thanks to modern emergency medicine, the vast majority of people survive their initial stroke. And, that's a triumph, obviously.
Absolutely.
But the long-term physical impairment left in the wake of that survival is just immense. The sources highlight this really sobering statistic.
Okay.
When you look at patients 3 months post-stroke, roughly 40% of survivors have significantly impaired function in their affected arm.
40%, wow.
Yeah, and another 40% are dealing with mild to moderate impairments.
Wait, so if we do the math there, 40 and 40 is 80. That means only 20% of survivors are retaining entirely normal arm function after 3 months.
That's right. You're looking at 80% of the stroke survivor population facing some level of daily physical struggle with their upper body.
That's a massive portion of people.
It is. And a major, very frequent complication that arises from that motor impairment is a condition called shoulder subluxation.
Subluxation.
Okay. Yeah, specifically inferior subluxation, which is the medical term for that heavy, dropped shoulder you described earlier.
Right, okay. I want to visualize what's actually happening under the skin there, because the shoulder, it isn't like a knee or an elbow, right?
No, not at all.
It's not this deeply locked-in hinge. I always kind of picture the shoulder joint like a golf ball sitting on a relatively flat golf tee.
That is a really great way to look at it. It's incredibly shallow.
Yeah, and that biological design, it gives us our amazing range of motion. It's why you can throw a baseball or scratch your own back, reach up to a high shelf.
Right.
But because that tee is so shallow, the golf ball, like the head of your upper arm bone, the humerus, isn't held in place by bone locking into bone.
No, it's not.
It's held in place almost entirely by a tight tape of very specific muscles and ligaments just wrapping around it.
And that's exactly the structural vulnerability of the human shoulder. The two key muscles pulling that duty are the supraspinatus and the posterior deltoid.
Okay, the supraspinatus and posterior deltoid.
Right. And their full-time job, 24 hours a day, is to counteract gravity. They keep that golf ball sucked tightly onto the tee.
So they're constantly working.
Constantly. But when a stroke causes hemiplegia, which is paralysis or severe weakness on one side of the body, the upper motor neurons in the brain are damaged.
Right.
So the brain suddenly stops sending that baseline electrical signal that tells those shoulder muscles to maintain their tension.
So the tape just instantly goes slack.
Exactly.
And the moment those muscles stop holding tension, gravity just pulls the weight of the entire arm downward. The humeral head literally slides down and out of the glenoid fossa, out of the socket.
That's the drop.
But here's the thing that I'm wondering: if the arm is paralyzed anyway, Why is a dropped shoulder joint more than just I don't know, a cosmetic issue? Like, why does the medical community care so deeply about this specific structural drop if the patient already can't move the arm?
Oh, because that structural drop, it sets off a brutal chain reaction. It can honestly derail the entire rehabilitation process.
Really? How so?
Well, when the bone drops out of the socket, all the surrounding soft tissues, the joint capsule and the ligaments, they are suddenly stretched, totally taut.
Oh, because they're catching the weight.
Right. They are forced to passively bear the dead weight of the arm.
Yeah,
And that is a job they were never biologically designed to do.
makes sense.
So over weeks and months, that excessive stretching causes micro tears. It causes severe inflammation.
Which means if you are a patient or, someone helping a loved one through rehab, you can't effectively work on regaining movement because the fundamental machinery is just out of alignment.
Exactly.
You can't rebuild the house if the foundation is actively sliding down the hill.
That's a perfect way to put it.
Mm.
Furthermore, if this subluxation happens early on during what we call the flaccid stage of stroke recovery, where the muscles are just completely limp, that massive tissue stretch can lead to debilitating pain.
I can imagine.
And you simply cannot push a patient through grueling physical therapy if every time they move, their shoulder feels like it's being torn apart.
Right.
Which brings us to the intervention. The brain's main power grid is down. The wires coming from the central command center are severed, meaning those shoulder muscles aren't getting the signal to stay tight.
Yep, the signal is gone.
But the muscles themselves and the local nerves right there in the shoulder, they're perfectly healthy, right?
They are. They're just sitting there in the dark, basically, waiting for a memo that isn't arriving.
So the medical field realized they needed a way to bypass the broken connection.
Enter functional electrical stimulation, FES.
FES.
Yeah, if the brain won't send the electrical current to fire the muscle, we can apply an external electrical current to do the job. We directly stimulate the motor nerves of those paralyzed muscles.
But the key word here is functional, right?
Mm.
It's not just random, shocking, like, those old novelty buzzer gags.
No, definitely not.
The clinical data notes they use a very specific electrical frequency, usually in the 10 to 50 hertz range.
Yeah.
Why that specific frequency? Like, what does a 10 to 50 hertz current actually do biologically?
Because it speaks the nervous system's language.
Okay. If you apply just a single low-frequency electrical pulse, the muscle will just give a quick, isolated twitch.
Like a spasm.
Right. And that's not helpful for holding a joint together. But when you increase the frequency to that 10 to 50 hertz sweet spot, the muscle fibers don't have time to relax between the pulses.
Oh, interesting.
The twitches basically blur together into one smooth, continuous, sustained contraction. It's called tetanic contraction.
Tetanic contraction.
Yes. So to the muscle, it feels exactly like the brain is telling it to hold steady. It artificially recreates the baseline muscle tone needed to pull that golf ball back onto the tee.
Okay, so functionally, it's like hot wiring a car or, I don't know, setting up a bypass generator for a hospital when the grid goes down.
Exactly.
But looking at the clinical protocols in these sources, the actual setup is remarkably unintimidating. I think when you say, electrical nerve stimulation, people might picture a patient strapped into some sci-fi whole-body suit with wires glued all over their chest.
Like Frankenstein's monster or something.
Right. But this is just simple, non-invasive surface electrodes.
Yeah, they're essentially just sticky pads placed right on the skin.
Just sticky pads?
Right, positioned precisely over the supraspinatus and the posterior deltoid. And the treatment is completely passive for the patient.
What do you mean by passive?
Well, in these trials, they didn't have to actively try to move during the stimulation. They just sat in a chair for 30 to 60 minutes a session, usually a few days a week, for a 4 to 6 week block.
And it's crucial to note this was happening alongside their normal physical therapy, right? They aren't just sitting in a dark room getting zapped.
No.
The conventional therapy doing proper arm positioning, early range of motion exercises, using supportive slings, that all continues.
Yes, all of it.
The FES is just an external battery pack layered on top to provide active, localized support.
The intention is pure structural defense. You are artificially keeping the joint mechanically sound.
So the million-dollar question is, if we hotwire the muscles, does it actually work? Does the shoulder go back into place?
Right, the moment of truth.
And to figure that out, this 2015 McGill University team conducted an incredibly ruthless review of the medical literature.
Ruthless is definitely the right word. They started by pulling 727 articles on the topic.
Wow, over 700.
Yeah, but they knew that in the world of physical therapy research, a lot of studies are skewed.
Oh, sure.
If a researcher knows which patient is getting the shiny new electrical therapy, they might, unconsciously measure that patient's shoulder a little more generously than the patient getting standard care.
Right, human bias creeps in, even if they don't mean to.
Exactly.
So if they throw out the biased, low-quality studies, I imagine the actual success rate of this electricity drops pretty drastically,
Like,
right?
it forces you to look at reality, yes.
Yeah.
They whittled those 700-plus articles down to just 10 gold standard trials.
Just 10.
Just 10. These were studies that utilized strict blinding, meaning the people evaluating the x-rays had absolutely no idea which patient received the FES and which didn't. They only wanted pure, uncompromised data.
And when you strip away all that bias and just look at the high-quality X-rays, the results revealed a very specific, highly time-sensitive victory.
They did.
They found that when FES was applied early, which they defined as within the first 6 months after the stroke, it resulted in a statistically significant reduction in the shoulder drop.
Yes.
The gap in the joint was reduced by an average of 4.9 millimeters compared to the patients who only received conventional therapy.
Which is a highly specific number.
It is, and honestly, I have to challenge the significance of it.
Okay, go for it.
4.9 millimeters. I'm visualizing a ruler right now, and that is roughly the width of a standard pencil eraser.
Yep, it's tiny.
Why on earth is the medical community and this McGill team celebrating such a microscopic shift in bone position?
What's fascinating here is that context is everything in human biomechanics.
Okay.
Think about it. If you move your car 5 millimeters, it doesn't matter at all. But inside a highly compact, precisely engineered biological space like the shoulder capsule, 4.9 millimeters is a massive expanse of real estate. Yes, that tiny distance is quite literally the difference between a dangerously stretched ligament that is constantly bearing weight and a ligament that actually has some slack in it.
So the pencil eraser is the tension breaker.
Exactly.
Closing that microscopic gap pulls the heavy humerus just far enough back into the glenoid fossa that the soft tissues can finally rest.
It removes the mechanical strain from the system entirely. And that newfound stability is what makes daily activities like getting a shirt over your head or being transferred from a bed to a wheelchair vastly more comfortable.
Because it's not tearing at the joint anymore.
Right. It protects the joint so that standard physical therapy is actually possible without causing further damage.
But there's a massive blinking caution light in this McGill study. That 4.9 millimeter foundation saving win only happened if the bypass generator was hooked up early.
Yeah, the window closes, and it closes hard.
What happens if you miss it?
Well, if the FES therapy was applied late, meaning they started the electrical sessions more than 6 months post-stroke, the reduction in the shoulder drop plummeted to an average of just 2.0 millimeters.
Oh, wow.
And critically, from a statistical standpoint, that reduction was deemed completely insignificant. It basically did nothing.
But why does the body just stop responding after 6 months? I mean, the muscle is still there, right?
Because the damage becomes entrenched. In the acute and subacute stages, those first few months, the tissues are still somewhat pliable.
Okay.
But once you hit the chronic stage, after 6 months, the ligaments have been stretched for so long, they begin to permanently deform.
Oh, I see.
The surrounding muscles might start developing contractures, literally shortening and hardening into a new, incorrect position.
That sounds painful.
It is. And once that structural remodeling happens, simply zapping a muscle with surface electrodes isn't enough force to undo months of anatomical distortion.
So you have this golden 6-month window, and if you get in early, you fix the structural drop. Logically, as a patient, you're thinking, okay, the bone is mechanically back in the socket, the ligaments aren't stretching anymore. That means the pain is going to vanish, and I'm going to start moving my arm normally again.
Right, that's the natural hope.
But here's where it gets really interesting and honestly highly frustrating. The data tells a much more complicated story.
It requires a serious resetting of expectations for sure. The McGill meta-analysis evaluated 3 distinct outcomes: the subluxation gap, shoulder pain, and actual motor function.
Okay.
While the bone gap saw that clear, significant improvement, the findings for pain and motor function were decidedly negative. Yeah. FES did not show a statistically significant effect in reducing shoulder pain, nor did it meaningfully improve overall upper arm motor function compared to just doing conventional therapy alone.
I need to wrap my head around this. The shoulder is physically sitting better in the socket. The tension is off the ligaments. How is it possible that the patients aren't in less pain and they can't move their arms any better?
To understand the disconnect there, you really have to look closely at how the clinical world actually measures movement. There is a profound difference between measuring an impairment and measuring a function.
What does that look like in practice? Like, how do they measure it differently?
Well, an impairment scale measures a highly specific, isolated biological response. For example, a researcher might use an electromyography machine, an EMG, to read whether a muscle fiber twitches.
Just a twitch.
Right. Or they might measure isolated joint motion, like with the Fugl-Meyer assessment, basically just seeing if you can flex a bicep while lying down.
Okay.
Some of the lower quality bias studies in the review used these impairment measures, saw the muscle contracting stronger, and excitedly reported that FES improved motor function.
Because the machine was literally shooting electricity into the muscle and forcing it to twitch, so the EMG lit up.
Exactly. It's a biological parlor trick, essentially.
Wow.
But the high-quality blinded studies, the ones that drove the negative finding in the meta-analysis, they used functional activity-based measures. They used tests like the Action Research Arm test.
And what does that involve?
That test doesn't care if your muscle twitches on a screen.
Yeah, right.
The physical therapist puts a wooden block on a table and says, pick this up and put it on that shelf.
Oh, an actual task.
Right. They ask the patient to pour water from a heavy jug into a glass. They ask them to turn a key in a stubborn lock.
That is a massive distinction. So to translate this for the listener, FES might bulk up your shoulder muscle and make it twitch beautifully on command, but a muscle twitch doesn't teach your brain how to grasp a coffee cup, lift it to your mouth, and tip it without spilling.
It fundamentally cannot. Motor function, actually performing human tasks, requires incredibly complex, highly coordinated signals from the brain to fire dozens of different muscle groups in a very precise sequence.
Right, it's a symphony.
Exactly. Surface electrical stimulation sitting on two shoulder muscles provides a static mechanical hold. It cannot replicate the neural choreography required to pour a glass of water. FES is a scaffold, basically. It is not a skill-building teacher.
So it solves the structural problem but doesn't rebuild the neural pathways.
Right.
But what about the pain? If the shoulder is supported and the ligaments aren't screaming from being stretched all day, shouldn't the pain scores absolutely plummet?
That's the logical assumption. And, it's what early researchers hypothesized too. But the higher quality data proved it wrong.
Really?
When researchers used rigorous, subjective numerical scales where patients actually rated their daily discomfort, there was no significant difference between the group getting the electricity and the control group.
How does the pain persist if the tension is gone? I don't get it.
Because post-stroke shoulder pain is notoriously complex. It is rarely just one thing. Early on, sure, it might primarily be the stretch pain from the flaccid joint drop. But as patients transition into the later stages of stroke recovery, they often develop spasticity. The nervous system starts misfiring, and instead of being loose and flaccid, the arm is pulled rigidly inward against the chest. The fist is clenched tight, and the muscles are locked in a constant painful cramp.
Oh, that sounds awful.
It is. And FES only addresses a loose shoulder. It does absolutely nothing to stop a spastic cramp.
And it doesn't fix the brain either, right?
Exactly. You also have to consider central post-stroke pain. The stroke literally damaged the pain centers in the brain itself.
Oh, wow.
So the brain starts interpreting normal sensations like just the brush of a shirt against the skin as burning agony. Pulling a bone 4.9 millimeters back into a socket with a sticky pad does not heal a damaged pain center in the cerebral cortex.
It is a highly targeted structural tool, not a blanket cure-all. But if FES is acting as this external bypass generator, just holding the bones together while it's turned on, what happens when the 4 to 6 weeks of physical therapy end and they permanently disconnect the machine? Does the shoulder just immediately fall out of the socket again?
That is the crucial clinical reality check. And the long-term follow-up data is pretty sobering. The researchers looked at assessments conducted weeks or even months after the FES sessions had officially ended.
And what did they find?
Unfortunately, that foundation-saving 4.9 millimeter improvement largely faded away.
Oh, wow. So once the machine is gone, the muscles just go back to sleep.
In the vast majority of the high-quality follow-up data, yes. Without the artificial 10 to 50 hertz signal keeping the supraspinatus awake, gravity took over again.
Right.
The shoulder drop gradually returned to levels virtually identical to the control group who never received FES in the first place.
It sounds identical to wearing braces on your teeth.
Oh, that's a good analogy.
Like, the metal brackets in the wire do a brilliant job of forcing your teeth into perfect structural alignment, right? But the day you get the braces taken off, if you refuse to wear your retainer, those teeth are going to shift right back to where they started.
Exactly. The biomechanics of the body always look for the path of least resistance. FES is the metal braces holding everything in line. But active, patient-driven neurological recovery, the brain actually rewiring itself to send its own signals, that is the retainer.
So as we look at the big picture here, how do clinicians actually use this? If it doesn't magically take away the pain, if it doesn't teach your hand to hold a key, and if the shoulder drops again the moment you turn the battery off, why are physical therapists bothering to use FES at all?
Because of what that temporary scaffolding enables you to do during that critical 6-month window.
Uh,
The clinical perspective highlighted in our sources is very clear on this. FES is a powerful, evidence-backed tool, but it is just a tool. By securely holding the shoulder in place by that pencil eraser width during the most vulnerable months of recovery, it prevents permanent, devastating soft tissue damage.
it buys the patient time.
Exactly.
It keeps the hardware completely intact and undamaged, while the physical therapists do the grueling, tedious work of trying to reboot the software.
It gives the patient the best possible biomechanical chance to participate in active rehabilitation.
Yeah.
I mean, if your shoulder isn't tearing itself apart, you can focus all your mental energy on trying to rebuild that neural connection to your hand.
So to wrap up this deep dive for everyone listening, the McGill review really cuts through a lot of the medical hype. FES is not going to instantly restore your ability to play the piano, and it's not going to magically erase the complex reality of post-stroke nerve pain.
No, it won't.
But if you or a loved one are in those crucial first 6 months post-stroke, this technology has the proven ability to pull a dislocating shoulder back into place by 4.9 millimeters. And in the tightly packed real estate of the human joint, that microscopic shift is a massive foundation-saving win that keeps the door open for the rest of rehab.
It does. But it also leaves us with a lingering, almost philosophical question about how we use medical technology. One that the field of neuroplasticity continues to grapple with.
Oh, I'm intrigued. What's the question?
Well, if FES perfectly mimics a voluntary muscle contraction by artificially bypassing the brain entirely, we have to ask, could our neuromuscular system eventually become too reliant on this electrical crutch?
Oh, wow.
Right. We know that the brain rewires itself, that neuroplasticity occurs specifically because it is forced to struggle. The brain senses a biological deficit and is forced to build a new neural pathway around the stroke damage to solve the problem.
So if we just fix it for them.
If we artificially solve the structural problem with an external battery pack, do we risk dampening the brain's internal drive to heal? How do we, as a medical community, balance giving the shoulder the artificial support it desperately needs to prevent injury without entirely removing the biological struggle that forces the brain to recover?
That is a fascinating tension. Where is the exact line between supporting a broken body and accidentally doing all the hard work for it?
It's a tough line to walk.
It really is. And that is something for you to mull over as you think about how we integrate advanced technology into human healing.
Thank you for joining us on this deep dive. Keep asking those hard questions. Keep looking for the why behind the medical headlines. And the next time you effortlessly reach for a simple cup of water, take just a second to appreciate the incredibly complex, invisible electrical signals making it all possible. We'll catch you on the next one.